Hey everyone, I'm Chef AJ and welcome to Healthy Living. My guest this evening is Dr. Garth Davis. Dr. Davis is a leader in the field of bariatric medicine. Dr. Garth Davis stars with his father, Dr. Robert Davis, on the hit show docu-reality medical series Big Medicine, and his recently published bestseller, The Expert's Guide to Weight Loss Surgery, The Expert's Guide to Weight Loss Surgery is available in bookstores nationwide. Please welcome Dr. Garth Davis.
Hello, AJ. How are you?
Hi. Well, so I've only known you for 2 weeks, and I already love you. And we met at the Get Healthy Marshall New Year, New You Health Fest, and you reminded me of one of my very favorite heroes in the plant-based movement. You were passionate. You weren't afraid to tell it like it is. You were funny. I swear, you were like a young Dr. McDougall, and you're the same astrological sign. You're a Taurus too. I mean, you're awesome.
I'm Aquarius.
Oh, you're Aquarius? I thought you were a Taurus. Uh-oh. Well, you
Does that
remind
ruin everything?
I thought you were a Taurus. You sure reminded me of Dr. McDougall. Well, I like you even more now. Aquariuses are one of my favorite signs. So I can't wait.
Well, that's a huge compliment. I love Dr. McDougall.
You're so you're so passionate, and we're so glad to have you on the team. So what I want to know before we get into all the questions from the listeners and find out more about what you really do day to day, how did you start getting into this plant-based thing? It's kind of you're in Texas, you're a bariatric surgeon, not the most likely candidate.
No, in fact, it was kind of odd. You go through. It's funny. I mean, people kind of know this, but I don't know if they completely know it. That in med school, there's just zero training on nutrition. I mean, zero. We don't mention nutrition, and disease isn't even thought of as having anything to do with nutrition. I mean, we're looking at the end stage of disease. We're looking at the actual disease itself, and we're looking at each person individually, and not just each person individually, but each organ system individually. So that the cardiologist is only concerned about the heart, and the diabetic doctor is only concerned about the blood sugar, et cetera, et cetera. And so the patient almost doesn't even exist. It's just
Yeah.
the disease.
Very compartmentalized, huh?
Very compartmentalized. So I mean, it also got to the point where when we're rounding on the floor, we would talk about we wouldn't talk about Mr. Smith in room 101. It was like the colon cancer in room 101.
Right. Yeah, exactly. I used to be a respiratory therapist, and I remember it's the same thing. It's like they're not even a person anymore. They're just their organs.
Right.
Yeah.
Just their organs. They're a bystander, and we're going in to treat the disease. And
Yes.
It's not this conspiracy. People are like, oh, doctors want to keep people sick. That's not at all.
No.
They're just doing what they're taught to do. And that is to, in my case, cut, and in another doctor's case, give medicine. But anyway, I got into this field of weight loss surgery, and it was interesting. People coming in, they're overweight. I've got a surgery that fixes them. It does an excellent job. But a few things, you start seeing all these people now doing food logs, and they're all eating exactly the same food. And in the beginning, I was a high protein guy. Everything has to be high protein. In fact, my book, Expert's Guide to Weight Loss Surgery, recommends a ZOD diet, which is very high protein. And I didn't see people people still looked kind of sick to me. I mean, they would lose weight, but they weren't exactly healthy. The surgery worked well, but then 2 years later, people were coming back with weight gain. And it started making me question, because every time I was like, you're coming back, you're gaining weight, what are you doing? Well, I'm eating eggs and bacon to get as much protein as I can for breakfast, and then I'm eating chicken for lunch to get the protein. Then I'm doing a protein shake, and then I'm doing steak at dinner. And I was like, oh.
Yeah.
And I was eating somewhat similar, so
right.
Every time I started gaining weight, I'd just go on Atkins diet because, in the ultimate of irony, in my hospital there was a Wendy's, and we got free Wendy's. So you can imagine. So
that's
and
good,
then
because if you have Wendy's in the hospital, then you can just keep the flow of patients coming.
Oh, I mean, can you imagine? And the funny thing is that it was lost. The irony was kind of lost on me at the time, and now seems so ridiculous. Can you imagine a patient with their IV pole in their hospital gown waiting in line for a double cheeseburger?
I absolutely can. You know why? Because in 1977, I was a freshman at the University of Pennsylvania, and at Children's Hospital, there was a McDonald's in the lobby.
Yeah.
And we'd see all the kids with the shaved heads from chemotherapy coming down to get their Happy Meal.
Oh, it's disgusting.
And that was more than 30 years ago. That was almost 40 years ago now.
Yeah, we've got a McDonald's in our heart hospital here.
It's crazy, huh?
Yeah, but so comes along, meet my wife, and we're gonna get married. We get married, and we're gonna have a baby. And I have to get my insurance, my life insurance policy, and I go and get checked, and I fail to get the top tier my health insurance policy because my cholesterol is high, my blood pressure is high, my liver function tests are high from fatty liver. Meanwhile, I also had all kinds of irritable bowel syndrome problems. I was a mess, but I kind of thought, I don't know, I kind of just had this feeling that as humans, that's what you're supposed to be. You know what I mean? Like you just get sick. Like I tell patients, you got diabetes, and they're like, oh yeah, okay, I expected that. It's like we just almost expect to be ill because we live in such a sick society. But it just didn't jive with me. It's like, God, I can't. How are we so sick? And then I started looking at data from around the world and how we compare. Because I thought, oh, we got to be the healthiest people in the world because we got the best healthcare system. And in fact, we're the least healthy people in the world. We got the lowest, despite spending way more per person on healthcare. We have the lowest longevity, highest diabetes. So I started, well, I'm going to start investigating this a bit. I'm going to start really looking into this. And I started looking into what other countries are eating, how they're eating. I started looking at a lot of big epidemiological studies, came upon the Adventist Health, which we could talk about, and really fascinated. The more and more I learned, at first it was like a detective case, but then it became too obvious to be a detective case. I mean, you don't need Sherlock Holmes to figure this one out. Everywhere I looked, the same answer kept coming. And so I started thinking, God, I need to stop eating all this meat. I need to start eating vegetables. And it was kind of just a series of events after that. The more I changed, the better I felt. The more my patients changed, the better they felt. And that's a long-winded answer to say that's how I kind of...
Right, but no, that's a great answer. But how long ago was that, may I ask?
8 years.
8 years ago, great.
Yeah.
And so your kids, how old are your kids? Because your kids are eating this way now, right?
Yeah, they're vegetarian. They're not quite vegan. I can't keep them away from the cheese. But my one daughter's 8, my other daughter's 6.
Okay.
And they wear their vegetarian flags proudly to school and everywhere they go. It's announced immediately. And why do you harm animals, et cetera, et cetera.
That's terrific. So just in case somebody's listening that isn't familiar with bariatric surgery and the procedure you do, just very briefly, what is it and why is it done?
So the surgery that we do, there's a few surgeries we do. So the most common is a sleeve gastrectomy where you make the stomach smaller, and the other surgery we do is a gastric bypass where we make a tiny little stomach and bring a piece of intestine to it. And it's done in really morbidly obese individuals, and this is a whole other complex thing because, of course, I started doing plant-based, and I thought, okay, well, I'm just going to treat all the patients plant-based, and we don't need to have surgery. That didn't work perfectly. Yeah. And so now what I have found is that, some patients they don't weigh that much. They do okay with plant-based. I don't have to operate them. So I do medical weight loss, which is basically a plant-based diet. Sometimes I use medicines. And then there are some people obesity is an interesting disease, but, there's all these genetic studies and functional MRI studies showing that, a certain group of people have a very, very hard time losing weight. And what the bypass and the sleeves do is make them satisfy with a smaller amount of food, take away a lot of cravings, and really help them where it's not like, food is a constant thought in their mind. And once that is gone, then I could really help them out with a good diet. Then they're interested in a good diet.
Now, I've never heard anyone say that it can take away cravings. How does making the stomach smaller or altering it in any way actually take away cravings?
Because what it does is it bypasses a hormone called ghrelin, which is secreted by part of the stomach, and by bypassing that hormone, that's a major predictor of hunger.
Did not know that. See?
Oh yeah. And there's the gastric bypass. In fact, it's interesting to look at MRIs. If you look at MRI in someone who's overweight before surgery, and you show them a hamburger, their brain just lights up like fireworks. But then if you do the surgery and then do the MRI and show them food, it doesn't light up as much.
Interesting.
And so it really does control cravings a lot.
Well, I did not know that. See, I'm glad I asked. Is this procedure reversible?
The bypass is, the sleeve is not. But I've done, who knows, 5,000. No one ever wants it reversed.
Nobody ever wants it.
No, people are very happy with it. The only people that want to reverse, I've reversed, I think, 5 out of my 5,000, and it was mainly, I think 3 of them had cancer.
Oh my!
And then 2 of them wanted to reverse.
Because I want to know, and I don't mean any disrespect here. I don't know a lot about what you do, but the few people I've met with this surgery are still quite overweight. So does this surgery work?
Oh gosh, the surgery works. It almost works too well. because it's become kind of this like, this is the end all be all, and it kind of takes the focus away from prevention and goes straight to treatment. But yeah, I mean, we have long-term studies on weight loss when people keep off about 60% of excess weight to 80% excess weight, which is a lot of weight. And so the surgery is super, super successful. There's always going to be outliers. The surgery is a tool. So, I think the reason that my patients do so well is that not only do we just do the surgery, but we also teach them to eat. The problem I see is these people get the weight loss surgery and then they're told to eat protein, and they're stuffing their face with, all these fatty, high protein foods and they're drinking protein shakes in order to get this, really made up protein number consumed every day, and it's making them fat and sick. And then they come and see me, and we change their diet, and they're happy as anything.
Yeah. Well, I've interviewed a few other medical doctors on this show that are not a big fan of that surgery. And one of the things one of the lady doctors said is that she believes it takes away all the pleasure and joy of eating. How would you respond to that?
I mean, these people talk and they have absolutely no idea. I hate it when people talk and they've got no clue what they're talking about.
Well,
that would be an example of just being a complete idiot in my opinion. I really hate it. It's just ridiculous. I mean, I think doctors think as soon as they get an MD, they know everything about it. No, these gastric bypass patients actually live extraordinarily. This idea of an obese person is fat and lazy is just so completely untrue. I mean, they get the surgery and they live extraordinary happy lives. And they eat and enjoy their food perfectly. They just enjoy a smaller amount and they can make better choices. But, I mean, to make that statement is just ridiculous. And we have 30-year studies on gastric bypass. And the quality of life goes up 95%. There's quality of life exams. The quality of a person's life goes up 95%. There's not a drug, there's not anything else in the world that could do that to a person. So anybody that says that has no idea what they're talking about.
Okay, well, I just, I'm not trying to be contrary, but I do like, and I love the way that you tell it like it is, so that's awesome.
Yeah, well, I'll tell that one like it is, because there's so many myths about these poor patients and these surgeries, and the myths are just like so utterly ridiculously untrue.
So how big is your stomach or our stomachs about right now in terms of size or volume, and how small does it get after the surgery?
It really varies because it's like how big is a balloon? I mean, you could blow up a balloon, right? And I mean, it could hold up to 2 liters, and we cut it down to holding about 20 cc's to 30 cc's. Most of my patients end up eating 6 to 8 ounces of food and feeling absolutely comfortable.
Well, because I don't know. Do you remember the night we had dinner together? I'm a volume eater, and I eat so much volume because I eat such calorie dilute food. I would imagine with a gastric bypass, you couldn't eat the kind of volumes that I'm used to eating.
Yeah, you wouldn't be able to do a purely volumetric diet. But, as time goes on, they can eat fairly normal. I've got family members that have had the surgery, and they eat. I mean, you wouldn't be sitting dinner with them and have any idea they had weight loss.
Oh, that's sad.
So the first few months to a year is the part that everybody knows about. That's when you really can't eat a lot. But long term, people, they could consume fairly well. But I don't think they could they couldn't eat like you all the time. I mean, they need some calorie dense food, which is what I use starches for.
Yeah. Are there people that you just don't operate on either because of their age or because of their psychological status, or is there anybody that wants this surgery as long as they are a certain weight they can have it?
No, we do a lot of counts. So we have a psychologist in my office who sees every single patient. No smoking, no alcoholism, no binge eating disorders. They have to get counseling beforehand. They have to pass cardiac clearance tests. They have to have an endoscopy. They have to go through nutritional training for at least 3 months. There's a whole host of things that the patients go through before they go through surgery.
Right. So it's just not like you wake up one day and you get it. They really have to do something to be a candidate.
Yeah, no, you can't just come in and say I want surgery and we schedule you. No, it's a big huge process. And then afterwards, we have support groups that meet regularly. We have cooking classes. We've got a dietitian who meets the patients all the time. I see the patients every few weeks. We have labs that are drawn. So it's a really involved kind of lifetime process.
Well, speaking of cooking classes, I hear that you're actually a PCRM cooking instructor yourself, so that's pretty fun.
I am, and I enjoy doing the cooking classes. I'm not the best cook in the world. My wife is fantastic, so she does them with me, and I kind of talk about the theory while she talks about the cooking. But, I mean, I love the PCRM class because it's just so easy, and my patients love it because A lot of my patients, they've got no concept of any other way of eating except eggs and bacon for breakfast and, steak and potato for dinner. That's their only. You tell them vegetarian, and they think you're talking about canned peas and carrots, and they have no concept.
Yeah.
And so they really love that class because they're like, I never thought about portobello fajitas, and so it really goes over well with my patients.
Right. So until I read your intro, I'll be honest, I wasn't aware you had a TV show. Where can we see it, and what is the show about, and how often does it air?
The show, they're not showing it much anymore. It was on pretty regularly in 2007 and 2008. It was a show called Big Medicine, where they just kind of followed my father and I around as we just kind of, focusing on taking care of the patients and how we did with the patients and what the surgery was like. It was kind of a, good look. They show it sometimes on TLC and sometimes on Discovery now.
Do you think could we possibly, because it sounds really interesting, do you think we could find it online anywhere, maybe on YouTube or?
I've never looked for it. I don't know. It was called Big Medicine, and then they were calling it something else later on, like My Fat is Killing Me or something like that.
I'm going to look for it.
Which is part of the reason I'm not doing the show anymore. It got so, I don't know what you would call it, like just too theatrical for me. Like, they made it so dramatic, but as they do in these shows.
I didn't realize your father was a doctor as well. Is he the same kind of doctor as you?
Yeah, same. We're partners.
So he's still practicing, huh?
He's still practicing, yeah. I think he's going to retire in about a year.
Have you convinced him to go plant-based yet?
Oh, no.
Okay.
You can't teach an old dog new tricks. I've tried. Look, he works out, and he never used to do that before, and he eats a lot more vegetables.
Good.
But I wouldn't say he's plant-based. My mom, however, is.
That's terrific.
Yeah.
So it says you graduated Phi Beta Kappa, so you're no slouch, huh? Pretty good. That's.
I did my study.
Very good. So we have so many questions, and this is great because we don't always get this many questions, but people are so interested in what you do. But before we get to them, let's talk about the rant, your very long rant. We could do the whole show just on the rant, but we can direct people where they see it. It's so well written, and I love it. I mean, that could be a lecture. I have it all printed out, and that could actually be a lecture.
I mean, I've got so that is part of my book that's coming out. So the book that I have coming out is called Proteinaholic, and it's about our country's obsession with protein. And that's just one section of it. My goal in my book, if I had to pick one reason that I see people just so addicted to eating meat, is because everyone thinks everyone wants their protein. I mean, the RDA for a man is 52 grams. We eat on average 100, and everybody, if you poll, everybody thinks they should be eating more. And so we're eating so much more protein than we need, and it's making us sick. And so that's one section of my book. My book's made up of a whole bunch of rants. There's a rant on diabetes, there's a rant on heart disease, there's a rant on longevity, there's a rant on cancer, on how much protein we need, and kind of the story of how I got to this. But I'll tell you the one that you got, the one you're talking about, the diabetes one, right? Hello? AJ? Hello?
Dr. Davis, are you still there?
Yeah, I'm still there.
That has never happened before, and we do apologize for the glitch. I got knocked off the computer. So please, we were talking about the book that you're writing, Proteinaholics, and please continue with what you were saying.
And so, basically I wrote the book because the number one problem I see in people is this obsession with protein. People are eating double the RDA recommended daily allowance, which, as Dr. Campbell said at our meeting, is the optimal, not the minimum someone should eat. And they're doing it because they somehow think protein is good for them. And so my book kind of is a series of rants showing that it's not good for you, that it could cause cancer, diabetes. The diabetes to me is fascinating, but the more and more, I even posted today on my Facebook page, again, that there's even more studies that just came out in the last American Journal of Clinical Nutrition, which further shows that diabetes is really a disorder of meat causing fat to go into the muscle cells, disrupting the insulin receptor production, so that your cells just aren't sensitive to insulin anymore.
Well, so many people just have it so wrong, and so many of your colleagues, diabetes, they don't think about it as being caused by fat or protein. They think, oh, sugar, sugar. And then people are so afraid to eat things like rice and potatoes, which would actually reverse their diabetes because all their doctors tell them it's too high glycemic and things like that.
Yeah, it's so insane because, see what happens is people measure. So they say, oh, your blood sugar's high, you've got diabetes. But the sugar is a symptom. It's not the actual problem. The problem is that your cells won't take the sugar inside the cell to feed the cell. That's what the problem is. And the reason it won't take the sugar inside the cell is because the receptors for the insulin are broken because there's fat inside the cell. And this has been very well studied. This is not groundbreaking stuff, but no one listens because everybody's got our head planted, deeply in the sand.
I thought you were going to say up their butt.
Yeah, they do. It drives me crazy. I gave a talk to a bunch of doctors recently, and I started mentioning all these studies, and they're looking at me like they've never heard this before.
Yeah.
And I'm mentioning big studies, and the studies are in the New England Journal of Medicine, and they're staring at me like, nope, I haven't heard about it. It's just crazy to me.
It must be so hard when you're in a profession like that, and you know something that could save so many people, and the other people just like actually look at you like almost like you're crazy.
Yeah, it's frustrating. Utterly frustrating.
I can't imagine what it's like. Well, let's get into some of these questions. The number one question. Well, first of all, when is the book coming out? When can we look forward to this book?
The book will be out in October, being published by Harper, and I'll kind of have announcements on stuff on Dr. Garth on Facebook.
Great. And I know you're going to be speaking at the Food is Medicine Conference in Atlanta, Georgia on November 17th. That's one of your upcoming speaking events that I know about for sure.
Is that true? I didn't know.
I don't know. Are you? Are you? Maybe you're not. Oh, gosh, I might have you mixed up. So let's scratch that. Where are you speaking? Where are you speaking next?
I'm speaking at the Mind Body Green event in the end of May.
And where's that at?
And that is in Maryville in Tucson.
Tucson, okay.
And then I don't know my next speaking engagement after that.
Do you have a website where people could look up so if they want to come hear you speak in person? Because you're so great to listen to in a lecture situation.
Oh, thank you very much. I actually don't, but that's a good idea. I think you to do that.
Absolutely. Good. Well, I'm glad we gave you a good idea. So the book's coming out in October. A lot of people are asking, do you ever do phone consults?
I don't. I'm I'm just so full.
Okay.
It's busy days, and I got to see my patients in the office and operate, and I just don't have a spare moment in the day. So I thought about doing phone consults. I just don't have any time.
I think they're asking that because maybe if they were considering this type of surgery and they were plant-based, they would rather go to you than somebody else. That's my guess why so many people are asking this.
Yeah, I get a lot of people asking for that and just for general, gentle dietary counseling. But so much of what I do is involved in actually seeing the patient, examining the patient. I have like X-ray machines in my office. I get labs, and it's frequent visits, and so it's very hard to do it long distance. It just doesn't work very well.
Okay, well, thank you for saying that. So if you can't answer any of these questions, obviously just say, for whatever reason you can't answer, but I'll just read them because people did take the time to
I could plead the fifth.
Yeah. Well, yeah, I mean, because I know that you can't actually give medical advice, but some of them are more general. And some of these things, like some of these questions about nutrients, I hear all the time from people.
Sure.
So Tammy writes, if the intestines absorb different nutrients as they pass through different areas of the intestines, are we not absorbing certain vitamins due to the fact that certain areas are stapled off?
Yes, that's for the gastric bypass. You've got receptors all along, but like, for instance, in the gastric bypass, it's bypassing the duodenum. The duodenum is a major area for absorption of iron, so gastric bypass patients can get low iron levels. And they can also get low calcium levels. That's a little bit sketchier, but they can get low calcium levels. But that's and low B12 levels. So we check our patients regularly for that. But if you take a multivitamin, typically we never see any of those deficiencies.
Mm-hmm. Well, very good. All right. Why do most people you see with this weight loss surgery simply eat smaller portions of the standard American diet? Maybe not you, but I think a lot of the surgeons. Doesn't this make their health worse in the long run?
So you mean post bypass or
Yeah,
eating standard American
and
diet?
not you, but most gastric bypass surgery
Yeah,
surgeons aren't you. They're not telling their patients to eat a healthy diet afterwards, like you are.
right. And that's exactly what happens. What they tell them, and this is told all the time, is they tell them that they need to eat 100 grams of protein a day. And so the patients are trying very hard to eat. That's if you talk to any gastric bypass patient and ask them what they're eating, they're going to say protein. All they talk about is protein, 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 and that's what drives that. They think that fruit is bad for them because fruit is a carb, and
Mm.
this has all been sold to them by their doctors.
Mm-hmm.
And their doctors don't know anything. I give talks to their doctors, and they hear me talking there. Then I get it. But I'm only touching a small surface of a large amount of people doing this surgery that are telling people the wrong thing afterwards. But the answer to that question is yes, eating a standard diet. And I tell my patients all the time, surgery is just a tool. If you eat what you've always eaten, you're going to get what you always got. I mean, if
Yeah,
you want to get healthy and you want to have a change in your life, you have to change your diet.
that makes sense. So SJ writes, many people I know who have had this surgery have gained their weight back. Aside from their terrible eating habits, how can they gain weight if the surgery was made to prevent it? How does that work?
Yeah, it's kind of interesting how that works. A couple things happen. Number one, when you lose fat on your body, your fat produces this hormone called leptin
Mm-hmm.
that goes to your brain and kind of tells you, leptin's supposed to tell your brain, okay, we got enough fat on the body. You start losing fat, and the leptin drops off. The brain thinks, oh my God, I'm losing my stores, because this is an ancient genetic encoding that basically, when we were living in times of feast or famine, it's going to be winter time. You better eat as much as you can before winter, and leptin was supposed to tell you that. So now the leptin starts shooting up, and the patients could start to regain hunger. The other thing is they're eating. A lot of times, a lot of patients that haven't been taught what to eat are eating what we call slider foods that go through real easily.
Mm-hmm.
The pounds are small, but if you eat foods that could go through it real quickly, then that food's going to get in real quickly. The other thing that happens is the metabolism slows tremendously. Anytime you lose weight, there was some really good studies done by this guy named Dr. Leibel. And what he did is he took patients and he took obese patients and put them in a lab setting, made them stay in the hospital, and he tried to make them lose weight. And what he found is everybody could lose 10% to 15% of weight. But when you got to 10 to 15% of weight loss, and everybody's experienced this, it will just come to a halting grind. And that halting grind is a metabolic response. Your body's metabolism slows. Now, he did the same study on really thin people, and what he was trying to do is make the thin people fat. They actually did this on prisoners. And they had the prisoners eat as much as they could. They said, can you imagine being a prisoner? Like, we're going to give you pizzas. We want you to eat 10,000 calories a day. Like,
And
sure.
did it work?
What's that?
Did it work?
No, they didn't. They could not get fat because
Right,
their body would.
that's so weird that you said that, because I'd love for you to either tell me where you read this research or give me the link, because I saw a BBC documentary called Why Thin People Can't Get Fat, where they force-fed these naturally slender people like 10,000 calories a day for 30 days, and they put them in those pods that they use when astronauts come back, and they couldn't make them gain weight. They were melting ice cream, and these people were sick from eating all these calories, but they couldn't make these thin people gain weight. So so is there a way to find out, like, the minute we're born, if we're going to be thin or fat, so that we can do better? Like
actually, yes. I mean, there are now. Well, we've got probably about 50 genes that have been correlated with obesity. Two main ones, and there'll be many more as we've got the gene encoding going on. There will be a time where we will know.
Wow, that's just so amazing. Now,
there's some interesting studies they had. Like this could only happen in the Netherlands, but twins, if you have twins and you give them up for adoption, they actually separate them at birth. And they did this great study where they followed these kids that were separated at birth, growing up in completely different environments, and they monitored, their height, their weight, their hair colors, all that kind of stuff. Weight was as inherited as height. I mean, it was. You could be, if you had a gene that predisposed you to obesity, you could grow up in a completely healthy, skinny family that eats healthy foods, and you'd still be overweight.
That's something. That's just not fair, because I didn't win the genetic lottery, and
you didn't win the genetic lottery, so you got to struggle.
I have to work really hard to, not be fat. It's just not.
Yeah, fair. And I tell my patients this all the time. It's like, listen, I could give you some tools But this is a journey and not a destination. It's
Yeah.
always going to be tough. And that's what happens with these gastric bypass patients. They get tooled, but they aren't taught how to use that tool properly, and then you'll see them gain weight back. But again, it's a small percentage of people. Most of the people do pretty well.
How long has this surgery been around, and who invented it? And I mean, that it just seems so. In a way, it kind of seems bizarre, to be honest. Like that we have,
Yeah,
because I don't think they do it in other countries, like where people are starving. I don't think they even have this surgery there.
yeah, it's pretty popular around the world. Actually,
Yeah.
very popular.
Wow.
It's actually now one of the most commonly performed surgical procedures. Um, because the rest of the world is also becoming obese. I mean, certainly, it's not happening in Ethiopia, but it's
You're right.
happening
That's
in parts of the world.
actually, I know somebody from there. That's the country I was thinking of. I don't think they have that surgery there. But when was it invented, and who invented it? It just seems
Well,
so.
it's been around for a long time now. What it started was, back in the 50s and stuff, people were getting lots of ulcers, and back then we didn't have the drugs for ulcers, so everybody that had ulcers had that part of their stomach cut out.
Wow.
And what they found was when you cut out part of their stomach, they all lost weight.
Interesting.
And so then they started doing it for weight loss. And there's been a lot of incarnations. There's been a lot of different surgeries that have come and gone because they were, they had too many problems or too many complications. The one of the big moves was in the early 2000s. We started doing them laparoscopically, where we weren't doing big incisions, but rather doing tiny little incisions and using little instruments. And this really was a big change for the surgery because it made it a lot less morbid, and people did extremely well with it. And
is that how you're doing it now? Are you doing it laparoscopy?
Yes.
Oh, that's very cool. That's
yeah, the whole thing's
great.
laparoscopic.
Well, that's interesting how some surgeries were developed, like I didn't know what you just said, but because like I had radiokeratotomy years ago, and that surgery was invented because somebody got a piece of glass in their eye, and when they removed it, he could see perfectly. So pretty cool.
Yeah.
I love this question from Enid. She says, "Thanks for all the help you give your lovely wife." How does she know that? My question is,
I always post online about my wife. So.
Okay. Anyway, her question is that she's watched your show, and she said that your clients often have to lose 50 to 100 pounds before the stomach surgery. Question 1, what did they do to lose that weight? And number 2, if they just lose the 50 to 100 pounds before the surgery, why couldn't they just keep doing what they were doing so not to have the procedure at all?
Yeah, good question. So we have them lose weight because it shrinks the liver. We don't 50 to 100 would be a lot. That would be a pretty big person. We usually try to have them lose about 5 to 10% of their weight. And we do that with just the kind of diets we're talking about: high fiber, decrease the calories, more fruits and vegetables, etc. We do a specialized shake diet right before surgery that's been shown to shrink the liver size because we have to get behind the liver to get to the stomach. And that helps lose some extra weight. And, it's back to that concept we were talking about earlier. Everybody can lose weight. I mean, none of my patients have come to me and never lost weight before. A lot of them, their first diet was 10 years old where they went to, quote unquote, fat camps. And so they've been losing weight all their life and then gaining it back and losing it and gaining it back. And the problem is that snapback when metabolism slows and the leptin increases, and the bypass helps ameliorate that some and blunt that response so that they could continue to lose weight and keep it off. So if you look at there was a great study called the Swedish obesity study where they took a group of overweight individuals and half of them went on diets and medicines to lose weight and half of them had the weight loss surgery. And then they looked at them 25 years later, the surgery group, the medicine group had all gained weight, not lost weight over time. And the surgery group had lost about 60% of their excess weight and kept it off. So it's a pretty dramatic difference over, standard diet.
Now, what is the criterion? Do your patients have to be a certain weight in order to be eligible?
Yeah.
Or do they have to have like diabetes or because
Yes.
Because somebody that there's
you have to have a body mass index above 40, which is, a measure of your weight in kilograms over your height in meters squared. And then so your BMI has to be above 40. If your BMI is between 35 and 40, you could have the sort of heart disease or sleep apnea, one of these diseases that we've got really good proof that the surgery helps. I mean, the surgery does like almost miraculous job of curing diabetes because when you bypass part of the intestine, it changes some of the hormones that have to do with diabetes. It's kind of a complex thing, but it does really good with diabetes. So they've been dropping the weight because of the effect on diabetes. So if you're diabetic, You don't necessarily have to be in that morbid obese category, but otherwise you have to be in a morbid obese category,
But they
which is a
wouldn't
BMI above 40.
but they'd have to be at least overweight, right? If they were diabetic, they couldn't.
Yes.
Yeah.
Yeah. There's research now where they're starting to talk about doing it in people that aren't even overweight.
Wow.
Because of the results.
How quickly does it reverse the diabetes?
Immediately in some people.
That's amazing. Because
yeah.
one of the listeners writes that their sister-in-law had the surgery to lose her baby weight. At what point does this surgery become unethical? But I would imagine that she had to meet the criterion if she was going to have the operation.
Yeah, we wouldn't. There's no such thing as doing it to lose your baby weight. I mean, this is not a cosmetic surgery. We don't do it for cosmesis.
I love this question, but we know the answer because we've already talked about your wife and your kids, but we've got a few of these. Is Dr. Davis single? Unfortunately, ladies or gentlemen, no, he is very, listen, you should go look at his picture without his shirt. You posted that on Facebook and I shared it. He has got one rockin' hard body, but no, unfortunately, he was already snapped up by a lovely woman. But it's always nice that people are asking though, you know?
Yeah, well, thank you. I'm flattered.
Yeah. So your patients have a history of gaining and losing, as most people do, because they say something like 98% of people that lose weight gain it all back within 2 years. Do you think it's worse when people gain and lose, or is it better if they just stay overweight? Because I've read studies that show that when you gain and lose, where you gain it back, sometimes is more dangerous.
Yeah, I mean, it can be hard on the system. It definitely, there's been a study showing that, when you lose rapidly, in one of these like crash diets, you also lose a lot of muscle that's hard to regain, and so your metabolism slows. And so what happens is you lose weight and then you gain back even more than you had before, and so you're like slowly diet yourself up to, it's like 2 steps, more overweight, 1 step back, 2 steps more overweight, 1 step back, so that you eventually, diet your way to obesity. But I mean, I think people get the wrong idea. Like, our patients are sick. These are, they've been overweight, most of them, since birth. Their whole family's overweight. They've tried, 50 different diets before. It's not like someone's rolling off the street saying, I got a little extra baby weight.
Sure.
And I want to do it. You would not get approved for surgery for that.
Of course.
I mean, the insurance wouldn't pay for it.
Right. Barbara wants to know if patients develop iron deficiency anemia as a result of the surgery or gastric ulcers.
Yeah, yes on both of those. Iron deficiency anemia, those are the 2 most common complications we see with the gastric bypass. So not so much with the sleeve, but with the gastric bypass. And because we bypass that duodenum, like I said, you can get iron deficiency. We usually only see it in premenopausal females that are having heavy menstrual cycles, because one thing the surgery does is when you lose fat, a lot of the hormones, because they're fat soluble, are stored in the fat, and you get a mobilization of the fat and of the hormones, and so people could have heavy menstrual cycles and they can't keep up with the iron. But I mean, 99% of the time, iron supplements fix that. And then ulcers are rare, but they can happen. But you just cannot have Motrin or Advil or ibuprofen or any of these medications that can tear up your stomach.
Sure. She also wants to know if patients regain their weight, can they have the procedure again? But I mean, how can you do it again? Their tummy's so small.
Yeah, no, you can't. There's certain things we could do in certain situations, but my policy on weight regain there's a procedure that used to be done called the lap band, where you just wrap a band around the stomach, and that caused a lot of problems, and people vomit a lot and cause bulimia, and not a good surgery. And so that surgery will change to like a bypass or a sleeve. But if you've had a bypass and you're gaining weight, my policy is no surgery. That we need to work on diet and exercise.
Yeah, I would imagine. Now, I don't know what this means, but maybe you will. Diana writes, if a patient has had Roux-en-Y surgery 15 years ago.
That's the gastric bypass.
Okay, and has had and still has chronic vitamin deficiencies, iron, D, B12, folate, thiamine, and associated health problems, memory issues, neuropathy, osteoporosis, and wishes now to eat a fat-free, whole food, plant-based diet, what supplements do you recommend? And can any of these health problems be reversed with a whole food, plant-based diet?
Absolutely. The reason people get those deficiencies is they're eating this high-protein diet that lacks any fruits and vegetables. They're not getting any of the phytochemicals, missing a lot of the vitamins. I have all my patients do B12 once a week, sublingual. And I have them do a multivitamin every day, a calcium supplement twice a day. and vitamin D once a week, and that typically reverses everything. And then their diets are the diet I tell my patients that aren't getting surgery. We do oatmeal and berries with some nut milk for breakfast. Lunch is like a bean soup or a salad with beans and lots of colored vegetables, and then snack is an apple and some almonds, and dinner can be a veggie stir fry or veggie chili. So it's kind of the same diet.
It's kind of what
my diet's the
yeah,
same.
it's kind of what we eat,
Yeah, exactly.
Yeah. So Bonnie says that she had gastric bypass surgery over 10 years ago. When she was healed, she was able to eat a regular sized meal and was surprised since she thought it would only be a very small amount. She asked the surgeon, and he told her that he doesn't make the stomach size that small because he wants his patients to live as normal a life as possible. That being said, since she can eat regular portion sized meals and wants to live a SOS-free, whole food, plant-based lifestyle, are there any foods that she should be eating more of due to the small intestine being shortened?
No, I mean the small intestine is not shortened that much, so no. I mean she should be eating exactly what any plant-based
what you
diet
just
is.
said. Yeah, that's what I thought.
I mean, really a high fiber diet. I can't say enough about fiber.
I love fiber because it fills you up with no calories.
Right. I mean, if you're eating fiber, I find that we make everything too complicated. But if you're going to want to count something, then count fiber and your steps. Fiber and your steps. You count those two things, you'll be in good shape. But I can't. I look at my patients' diet logs, and they're getting less than 10 grams of fiber when they come in. I'm like, this is crazy, and I want them eating 35 grams of fiber. But really, just a whole food plant-based diet is the answer, and just about any question you can ask me.
That's right. Well, except for are you single? Then that that would be the only one.
Well, it'll be like depends. Are you a whole food plant-based diet eating person?
Exactly. It's like remember at the conference where we asked Dr. Oswald, who is single, what he was looking for in a mate, and he said somebody who's plant-based and awesome. So
yeah, that's exactly right. I could not. It's funny now. I could not. Thank God my wife went on the trip with me, because at this point, there's no way I could be married to someone who wasn't.
That's right. Yeah.
It wouldn't work well.
Have you ever read the book The Pleasure Trap by Lyle and Goldhammer?
Yes.
Excellent. I've interviewed Dr. Goldhammer twice on the show, and I'm interviewing Dr. Lyle last week. And one of the things I learned from the book is something called the mechanisms of satiation: the stretch receptors, the nutrient receptors, and the calorie receptors. So if we have these three receptors that are telling us whether we're full or not, lining our digestive tract, and you're cutting out a lot of it, what happens to the mechanisms of satiation and all these receptors? I mean, do they still work?
Yeah, they do. So some of those things are not exactly scientific. Like the calorie receptor, there's not a calorie receptor per se. The satiation mechanism is a little bit more complex than that. One of the main satiators is the stretch receptor, which is monitored by this nerve called the vagus nerve. By making the stomach smaller, less food will cause that stretch. So they get that stretch receptor. They may have never felt full before, which a lot of the patients talk about. Now they can actually feel it, which is a small portion of food. And then one of the other big satiating factors is this hormone ghrelin, and we're bypassing that. Then there's another one called GLP-1, and we're increasing that. So they just get a lot. If you look at it's interesting actually. If you take a person who's overweight and you do a functional MRI study of their brain, and you compare it to an alcoholic or a cocaine addict, it's very similar in that it lacks dopamine receptors. And if you lack dopamine receptors in your brain, it's very difficult to get a feeling of satisfaction. And so that a lot of times that's what the problem is. They're just not getting enough feeling of satisfaction. But through very complex hormonal problems, we're even now finding with the weight loss surgery, it may be a change in the bowel bacteria that's a large part.
Yeah, you talked about that in your lecture where they transplanted fecal stuff. It was kind of creepy, but you said that was kind of fascinating.
Yeah, it's fascinating. I mean, our bowel bacteria may be as important as anything in control of our weight and our diabetes and our heart disease, and it's a very new field, and it's being studied intensively right now. But the data is just dramatic, and like the incident I was talking about was because the one thing that we know is if you take one of my vegetarian doctor friends was laughing because all this time they've been saying being vegetarian is bad for you, being vegan is bad for you. Now all of a sudden they want poop from vegetarians.
Well, they can have mine
because it's the healthiest. But basically what happened was they know that getting bacteria from one person and giving it to someone who has this bacteria called C. diff colitis. So you could get this infection in your colon called C. diff, and it's become antibiotic resistant. But if you take someone else's bacteria from their bowels, you could get rid of the C. diff. And this lady had that done, and she got stool from her daughter, but her daughter was morbidly obese, taking after the dad's side of the family. And within 6 months, the skinny lady became morbidly obese.
Wow.
So the bacteria might have a lot to do with it.
That's so note to self, get it from a skinny person.
Get it from a skinny person, preferably a vegetarian.
Wow. So you were saying that the dopamine, where the people, where are they going to get it? Where are they going to get it if these people are overeating because they're looking for dopamine? Where do you suggest we get it then?
Well, I mean, the certain things make you kind of so, like, let's take for instance cheese. Everybody loves cheese. So cheese has in it a substance called casomorphine, which acts just like morphine, and so that provides this pleasure response that they're just not getting in general. So they get this pleasure response and like, oh my God, that feels good, I need that more, and all of a sudden they're addicted to cheese. Same thing can happen with sugar. And so really you've got to, it's kind of like a cocaine addict or an alcoholic. You got to avoid the foods that set off this response, and you've got to fill your body up with you mentioned nutrient satiation, but you do that's real, and you got to have the nutrients your body needs, otherwise it'll be searching for nutrients, and you got to fill up your stomach so you get that stretch receptor filled, and we have to and keep your metabolism going by being active. And if you do all those things, you can kind of overcome, you don't have to be like the talk I gave at Marshall. You're not a slave to your genes. You can't overcome it.
Yeah, that's good. So how do you feel about food addiction? Because some of the people I interview poo-poo it, and other people that are considered experts believe it's completely real.
No, it's. I mean, gosh, it's absolutely real, but it's real with a genetic background too. Like the thing that gets me more than anything is when people say obesity is not a disease. These people are just choosing this life, and they're late. I mean, that's just flat out wrong.
Yeah.
And that's been, there's so much science behind. I mean, there's clear genetic disorder, and the genetic disorder creates a situation where you could easily get yourself into addiction, which is the same thing with alcoholism and all that kind of stuff. Which is why sometimes in our gastric bypass patients we can see cross addiction, where a lot of people were trying to overcome this lack of dopamine receptors by eating. Eating became their drug. We take away their ability to eat a lot. And then they could be like, well, let me start drinking.
I know one person that actually happened to. But how much do you think is the environment, Dr. Davis? Because if these people were born, say, in Ethiopia, even with the genetic predisposition, would they then just not become obese because the environment just would not support this?
Exactly. So if you look at, for instance, like the Japanese or the Okinawans, they're very healthy. They live these long, healthy lives. And we thought these people are resistant to getting diabetes because they just didn't get it. Moved to America, moved to Hawaii in one study, boom, obesity and diabetes. And so, there's look at the, I think the Pacific Islanders are interesting. They got the highest rate of obesity and stuff. But if you go to like there's this one archipelago that they're like part of the islands are what you would call quote unquote civilized. They're not eating the kind of native diet. They're eating a more westernized diet. Lots of obesity, lots of diabetes. But if you look at the parts that aren't civilized, where they're eating a more rural diet, made mainly of fruits and coconuts and things like that, no diabetes, no obesity. So that's an example. With diseases in medicine, we have what's called a two-hit hypothesis. So, like, for instance, in order to get melanoma, you have to have a gene that predisposes to melanoma. You have to go out in the sun and get that gene activated. Here we got a gene that predisposes to obesity that makes you hungry, and there's McDonald's on every corner. And we're not walking. We drive everywhere. We have remote controls. And so it's really kind of this, horrible combination of events that's led to this problem.
I imagine if your patients, if they have a BMI of over 40 and are morbidly obese, they're probably not doing much exercise. So is that something that you talk to them about, or do you wait till they take the weight off first?
Well, I talked to them about it. I mean, most of my patients, are waiting. They're sent to me because their knee doctor won't operate on their knee till they lose weight. Their
Got
knees
it.
bone on bone and their hips bone on bone. So
Yeah.
it's hard for me to look at this person that comes in a cane and tell them, I want you to go out and run 5 miles. And the funny enough is exercise is not. I mean, exercise seems to do great for maintaining weight loss and preventing weight regain.
Mhm.
Not a fantastic job at losing weight.
Okay.
What I basically want my patients to do is be active. And so what I start with my patients doing, I love pedometers.
Yeah. Too.
And so I really love that kind of biofeedback, these reminders to walk, because we've forgotten to walk. We can't rely on ourselves. And so this kind of gives a reminder to get 10,000 steps a day, and that's correlated very, very well with good weight loss, both in post-surgical patients and non-surgical patients.
Mhm. So what do you do for fitness? Because you didn't look as fit before you were plant-based as you do now. Is that
Right.
because of the diet or because you actually increased your exercise at the same time?
No, it's both. I mean, once I started the diet and I started losing weight, feeling like unbelievable amounts of energy, I started kind of getting excited about it, and I started, I was like, man, I wonder if I could, if I could run. And I started running, and I started swimming, I started doing triathlons, and now, I do a combination of weightlifting, running, and swimming, and biking, and just being healthy every day, doing something active.
I loved when we had dinner. I don't remember exactly what you said, but we were talking about this with the other doctors, and you said something like it. You're like, "Well, why doesn't everybody just get this?" And I'm like, "Yeah, why not?" It's
Yeah,
like,
I know. I mean, I read this article by this guy Fontana, and he had such a good point. He was like, a plant-based diet is phenomenal for the environment. It's ethically responsible. We're torturing these animals, and it's fantastic for your body. Why in the world aren't we doing this?
yeah.
And
Well, I don't know.
I
I've
don't
been
know.
doing it almost 40 years. I ask myself that every day. So I thank you for. Well, see, when guys like you are doing it and doctors, I just think it helps. It helps so much because you guys are so respected, and you have a reach of your patients that maybe I wouldn't be able to reach these people. So it's terrific.
Right.
So thanks. So yeah, I can't help it. I can't get these stretch receptors out of my mind because I really want to know more about them. And do we have a genetic predisposition to how sensitive our stretch receptors are? And the reason I ask is I have this very naturally slender husband. He's 6 feet and 140 pounds. When we ate oil, he was 160, but he was still slender. And I've struggled with my weight all my life. And it takes me an enormous amount of food to feel full. And he could eat. It's almost like he's had gastric bypass. He just is like, oh, I'm so full, and he hasn't eaten anything.
Right.
So is this? What is this? Why? I mean, it doesn't seem fair. Like, why can he really sense accurately like the fullness of his meals? And me, I pretty much have to overeat at every meal to feel full. And if it wasn't for calorie density, I'd still be obese.
Yeah, isn't that fascinating? And
Yeah,
that's what we see every day. And that's why I try to explain to people that obesity is not this it's not like this choices. So some of these people that you just never feel full. And it has a lot to do with, I think, with these dopamine receptors in your brain. You have less dopamine receptors in your brain.
I'm sure I.
It might be stretch receptor. I haven't seen an actual study on stretch receptor. They're doing this new trials now we've got this new, I don't think this is going to work very well, but it's this new little nerve stimulator that we put into the stomach, and it actually stimulates the nerves from the stretch receptor,
Interesting.
to try to make a sensation of fullness. But there is, without a doubt, a difference. Like I always tell people, you got to walk a mile in someone else's shoes to understand. There's a huge difference in what one person. Like, I can't stand when someone says, "Oh, they should just eat the way I eat. I just don't eat that much." Well, I mean, it's easy for you to say.
I
You're
know.
constantly hungry,
Well,
and
there's not a
there's
lot
a
of
big difference.
empathy, I think, and a lot of, I mean, it's funny because I've been on both sides. I've never been morbidly obese, but I've been obese, I've been anorexic, and I've been normal weight. And there doesn't seem to be a lot of compassion of people that are normal weight that have never been overweight for people that have this particular problem. Because I do think, like you say, it's a problem in the brain. Not that they're mentally
Right.
ill, but maybe just not getting enough dopamine. And they're like, well, why can't you just push yourself away from the table? And that's like a non-alcoholic telling an alcoholic, well, why don't you just stop at one drink? And they don't get it. They don't get it.
Right. Exactly. And
It's
that's what I struggle with a lot when I'm talking to people and even doctors.
Yeah, it's very frustrating. So, do you think that it's harder for people that have been overweight or obese as children to get a handle on this than, let's say, like people that go to college and gain the freshman 10, or where maybe it's just because they're drinking beer or something? Is it do you see a pattern with the people that you operate on that it's been a lifelong struggle, or are they
Yeah,
just
the lifelong struggle. I mean, the thing about fat cells is once you form them, especially young in life, I mean, they're always there. And when you lose fat, you don't lose fat cells. You lose the amount of fat in each cell, but those cells are just waiting for your next meal. And so, yeah, it's very difficult for someone who's been overweight as a child. And most of my patients, the vast majority, have been overweight since they were young. 18% of our kids are morbidly obese right now, and
right?
80% of kids that are obese are going to be obese adults. So
Yeah.
we're just building a huge population of obesity, and so it's definitely worse in that situation. Definitely.
Yeah, I just spoke at a childhood obesity summit yesterday, and it's really really getting bad. It's crazy. So I always ask this to just about everybody I interview, and it doesn't have to be somebody in the plant-based movement, but maybe it is. So who inspired you, or who inspires you?
Well, initially one of my big inspirations were actually my patients, because I would see these patients back, that have been losing weight. And it's amazing to me because now I look at people, and in life we get into such a rut. We kind of develop this kind of like idea of who we are, and we have these like I was a hamburger eater. I liked hamburgers. I didn't like vegetables. I hated broccoli. That's just who I am. That's what I thought. And I don't exercise. I'm not an athlete. That's who I am. And we get into adulthood, and we have these very strong kind of ideas. And I would see these patients with these same, they're in a rut, right? You go to work, you come home, you plop down on TV. I did the same thing, eat a hamburger, and that's it. Mm-hmm. And I never thought there was an escape from that pattern. And I would see these patients, and they would get the surgery, and they lose the weight, and they'd be so excited about life, they'd go run a marathon. And I thought to myself, God, it would be great to like do something completely different. And so my patients were a huge inspiration for me in changing my life. I wanted to, first of all, I wanted to not just talk the talk, but actually walk the walk and be an inspiration to them. But they were also an inspiration to me to get up and get moving. Dean Ornish has been a huge inspiration to me. His research is just mind-boggling to me. His research, he should have won a Nobel Prize for the stuff he's done. And I mean, his most recent work showing that plant-based diet actually changes the chromosome.
Yes, telomeres. Right.
Yeah, the telomere. It's just absolutely flabbergasting. It really should be up for a Nobel Prize. So his stuff is incredible. Neil Barnard and the absolutely dedicated work that he does for Physicians Committee for Responsible Medicine, fighting on so many levels, fighting for our nutrition, fighting for nutrition in schools, fighting for nutrition education in medical school. He is probably my biggest inspiration. I really, really have a lot of respect for Neil Barnard.
Yep, we'll be interviewing him in about 3 weeks. It's interesting because I was on the treadmill today and watching something on the History Channel about Copernicus, and he was, I don't know if you know about his life, but he could basically, that he was ostracized for telling the truth and kept a lot of his secrets to his deathbed. But then, of course, now we realize he was right. And I have a feeling that a lot of these people you mentioned that didn't win the Nobel Prizes, way down the road, people will look back and say, wow, they knew this all, Dean Ornish knew this in 1980. You know what I mean? That's what I think is going to happen.
Yeah, Dean Ornish should get the Nobel Prize for science, and Neil Barnard should get it for peace.
Yeah,
because of
exactly.
him and Gene Bauer. We'll give it to both.
They're awesome. So what would, if there was a Nobel Prize category for you, what would you get it for?
Being a little bit the Nobel Prize for loudness about the topic.
I loved you. I just was so excited to see you. You're fun. You're passionate, and you're a good speaker. And I that's why I really want you to get that website up, because I don't. How else are people going to know where you are? They need to see you, because you're as great as you are on the phone. You're even. You're more dynamic in person, and we so look forward to your book coming out in October. So that's really what's next for you. You got the book coming out, and that's your next big thing.
I'll do a lot of talking after the book comes out. Harper wants me to go on book tours and stuff. And I hope the book is just so loaded with science. My wife is like sick of this book, and so my kids. My 5-year-old was like, "Are you done with the book yet? I'm going to be so excited when you are." Because I've just spent my weekends in libraries looking at research and doing this kind of investigating to the nth degree, and I've got so much science proving the benefit of a plant-based diet. It's almost you can't argue. although people will, but
Yeah.
I just don't know how they will because the science is just so overwhelming.
Yeah. Well, the same way they argue that butter is good for us, they'll find a way. They'll find a way.
Yeah. One guy said to me, he's like, "You're just cherry picking articles." I'm like, "There's 1,000 articles in this book. If I'm cherry picking, it's quite a harvest." So
right.
that's a lot of data for him to deal with.
That's so good that you're writing about that because, doing this for almost 40 years, if I had just a nickel for every time somebody said, where do you get your protein? Boy, that gets really, really annoying. Well, it's been absolutely a pleasure talking to you. This hour just went by, and I cannot wait to read your book and hear you speak again, hopefully soon. So thank you so much for
Thank you, AJ. It was a pleasure. Pleasure meeting you. I loved hearing you talk too. And look forward to doing more with you.
Absolutely. We're both invited. We're two of the speakers invited back next year for Get Healthy Marshall.
That's right.
Yeah, with Dr.
Hopefully we'll see you before then.
Yeah, the same here. So thank you so much, Dr. Garth Davis, and thank you so much for listening to Healthy Living. I'm Chef AJ, and I make healthy taste delicious. Good night, everyone.